Just a minute, I'll just. Yeah.
Yeah. A very good afternoon to everybody. We welcome you all to yet another webinar of the Indian Academy of Neurology Outreach Subsection. So we all know that stroke remains one of the leading cause of disability and death worldwide, and it is affecting millions of people, individuals, families, and communities each year. The World Health Assembly resolution makes a significant milestone, recognizing stroke not merely as a neurological condition, but as a major public health priority. Now, it reflects a community collective commitment by all nations to strengthen the prevention, improve access, expand the rehabilitation services, and reduce inequities in care. For people with stroke and their caregivers, this resolution is representing a lot of hope for better awareness and stronger health systems and probably an improved quality of life. Today, we have the opportunity to explore what this landmark resolution means in practice, what it happens in real life world, and how it can translate into better outcomes for people around the world. I'm very delighted to welcome our distinguished speaker, Dr. Jairaj Pandian. He's a globally respected neurologist, clinical scientist, and one of the foremost leaders in stroke care and advocacy. Dr. Pandian serves as a professor of neurology and has made pioneering contribution to advancing stroke services research. Professor Pandian has got more than 340 peer-reviewed publications with a huge citation and an H index, and his areas of specialty are stroke epidemiology, systems of care, reperfusion therapies, stroke rehabilitation. He has several achievements and awards to his credit, of which the WSO, World Stroke Organization Global Stroke Service Award in 2020 for his contributions in the field of stroke, Career 360 National Award for Stroke and Best Medical Teacher in 2023, Sitaram Jaipuria National Award for Medical Excellence and Research in 2023, National PI for the Indian Stroke Clinical Trial Network, and CM is the only WHO collaborating center in the world. He's a passionate advocate for reducing the global burden of stroke. We have seen him for years now, and all through his time now, he has been instrumental in the World Stroke Assembly as well, and we are going to learn that. His extensive research, mentorship, and policy engagement is going to give us a fresh light on what the World Health Assembly resolution is going to stand here. So let us hear and let us warmly welcome Professor Pandian, and let us hear from him, and let us have a question and answers in the chat box if you have any, and that would be addressed to the speaker. Thank you very much. Professor Pandian,
Yeah,
over
thank
to
you. Thank you, Dr. Bindu Bennett. And first of all, I thank IA and the outreach section, the subsection, for inviting me. I will share my slides. So what I am going to do is quickly talk about the global burden of stroke and the burden of stroke in India, and then World Stroke Organization, some of the initiatives that we have, and then we will discuss about the advocacy and the World Health Assembly resolution. So burden of stroke, this slide is from the WHO fact sheet, about 12 million new strokes, 7 million deaths, 94 million prevalent cases. And if you look at the map, you can see that Delhi's in millions, disability adjusted life years. So Asia and Africa, if you combine together, which covers two-thirds of the strokes in the world. And 1 in 4 people will have a stroke in their lifetime. And we also need to know that 89% of the strokes occur in low and middle income countries. This is a heat map, a global heat map on age standard rates of stroke incidence. You can see the anything, orange, brown, dark brown, red, maroon. Now it shows high rates of stroke that you can see Asia and Africa. A similar picture you see in terms of prevalence. So maybe it's a little bit of variation, but largely in Asia, Africa, and you can look at the Southeast Asia region also. So this is the global burden of stroke, and this is the burden of ICH. It constitutes about 29% of the incident strokes and 46% of all stroke deaths, and almost 50% of the dialysis due to stroke. And you look at the map here, and you can see Asia. There is a huge burden of intracerebral hemorrhage. Stroke facts from India: we have 1.8 million strokes per year. One stroke every 4 minutes in India. Every 40 seconds, one Indian suffers a stroke. So close to 4,500 strokes a day. And this slide summarizes the prevalence, incidence, and case fatality rate. Um, no, and case fatality rate is high, 22 to 42%. There is a new data from Dibrugarh, which is about 62%. And this is a recently published paper from Hospital-Based Stroke Registry in India. And this is a summary. You can see about 30 hospitals, about 34,000 patients were recruited. And a good proportion of the stroke patients, about 14%, are below 45 years of age. And major risk factors: hypertension. There is a treatment gap. And you can see your a very 20% reached hospital within 4.5 hours. The thrombolysis rate is 4.6%. Thrombectomy rate is less than 1%. And outcomes, you can look at the mortality. Almost 28% death at 3 months, and almost 30% are left with disability, and poor outcome is more than 50%. So this is a figure from the hospital-based stroke registry, which shows that a lot has to be done for the stroke care in India. And this is a recent verbal autopsy data from our Ludhiana Rural Population-Based Stroke Registry. We did the verbal autopsy of all the deaths in about 146 villages, 1,182 deaths, and 22% of the deaths were due to stroke. And stroke was the leading cause of death. Hypertension, almost 70, 87, 82% of the patients. And if you look at the time of occurrence of death, in 83% of the stroke deaths occurred within 30 days of symptom onset, and out of that, 48% within 7 days. That means, it reflects on the access to acute care and the gaps that we have in our country. So moving on from the global burden and burden of stroke in India to World Stroke Organization, this is a global organization formed in 2006, and we are recognized as a lead global organization for stroke by WHO. And we also have United Nations Economic and Social Council status. We have more than 3,500 members, and from 95 countries, 40 board members, and 11 executive committee members. So our vision is a world free from stroke, and our mission is to reduce the global burden of stroke through prevention, treatment, and continuity of care. So, what are the strategies? This is an important paper that was published in Lancet Neurology in 2023, looking at a pragmatic solution to reduce the global burden of stroke, a WHO Lancet Neurology Commission. So, we approach this in 4 pillars: surveillance, prevention, and rehabilitation, and acute care. So, these 4 pillars are important when I discuss about the World Health Assembly stroke resolution. An integrated approach is needed. All these four, we can't do it in silo, and it has to be integrated. So these are several initiatives of WHO. We work on advocacy, stroke awareness, capacity building, and the academic part, and then implementation of stroke care, WHO Stroke Center certification, stroke support organization, and training future stroke leaders for the world. The effective advocacy, this slide summarizes the advocacy done so far since 2006. The first major one was the ICD-11 classification, where stroke is into the cerebrovascular diseases category. That itself was a major task. Then inclusion of TPA in the WHO essential list of medicine. Then we worked closely with the WHO headquarters for coming up with the arts technical package. That region level, some of our members and office bearers were involved in the development of European Stroke Action Plan. I was involved with WHO CRO to develop a stroke care program for CRO countries, and also WHO policy program, or WHO regional summit. And we also closely work with countries who approach us for developing national stroke action plans and also implementation program. So in the year October 2024, we approved a major initiative called Global Stroke Action Coalition, and basically this was launched in April 25. It's a partnership between the industry and the organizations and the advantages of working together is leverage on the strengths, expertise, pool all the resources, and improves the efficiency, and also builds local ownership and sustainability. So, advancing policy action on stroke. So, these are the coalition members. You can see the European Stroke Organization, the Asia Pacific Stroke Organization, and several professional societies, and also the industry partners. We had five urgent actions to reduce stroke burden, make stroke as a priority in city health strategies, develops national stroke action plans, commit to funding, implement robust monitoring system, and include the stroke survivors and caregivers in policy development. So first um, uh, World Health Assembly side event was in last year on May 19th, and we had several ministers from different countries participating, including WHO headquarters and the industry partners, and also the patient survivors. And then we moved on to the United Nations meeting on 26 September last year. Our executive director, Mia Kruper, and me, we participated in the NCD summit, and we were able to make statements. And we also had a side event, which was attended by seven ministries of health and about 55 participants, and all emphasizing on the importance of stroke, and stroke needs to be taken as an important NCD in stroke advocacy. So these collective efforts, which resulted in countries like Egypt, Tunisia, Georgia, Chile, Palestine, and Paraguay. I have visited Egypt, Tunisia, and Georgia, met the health ministers of these countries, and through them, we were able to develop a resolution. And the Ministry of Health Egypt submitted it, and it was discussed in the executive board of WHO, and it was approved on 3rd February 2026. Then there are processes, two important steps. That is where the World Health Assembly in Geneva, May 22nd and May 23rd are two important dates for stroke resolution. And I'll just show you the first opportunity was that I was able to make a statement, and the second was the resolution submitted by Egypt and supported by several countries were discussed in the regional committee meeting, and then it got approved. And then the final World Health Assembly meeting, which was on 24th, where they take all the approvals of different committees, and they approve. So this is how the resolution looks like, and I will take it up. And this is the statement which I
World Stroke Organization, to be followed by China.
This statement is delivered by the World Stroke Organization on behalf of NCD Alliance, World Heart Federation, International Diabetes Federation, World Hypertension League, International Society of Nephrology, Handicap International Federation. Honorable Chair, distinguished delegates, we welcome the resolution on reducing the burden of stroke as an important opportunity to advance global health, UHC, and development goals through equitable, effective, and coordinated stroke care across the patient pathway. Stroke causes 7 million deaths and 145 million dailies. Videos are important. And the next day after the statement, this was taken up for discussion. Several countries supported, at least I would say about 7 countries supported this resolution, in addition to the countries who proposed about 5 of them. And this is regional committee approval.
Is the committee now ready to approve the draft resolution entitled Reducing the Burden of Stroke? Strengthening prevention, acute care, rehabilitation and health system readiness, contained in Resolution EB 158.R4.
And then the next is in the main assembly when they bring in all the
I see no objections. The resolution is approved.
Approval. I'll just show this video.
La tercera resolución lleva por título reducir la carga del accidente cerebrovascular, reforzar la prevención, la atención en la fase aguda, la rehabilitación y la disposición operativa en los sistemas de salud. ¿Desea la Asamblea adoptar esta resolución? No veo objeciones. La resolución queda adoptada.
For the first time in history, the World Health Assembly declared stroke a global priority. Adopting a resolution on stroke, country leaders from around the world committed to act. Every year, 12 million people experience a stroke. 7 million die, and millions are left with lasting disability. Today marks a turning point.
For people like me,
this resolution is the result of years of effort from survivors, clinicians, advocates, and policymakers who fought to put stroke on the agenda. But this is only the beginning. Its power lies in what comes next, in how it is time to act on stroke.
So this particular Global Stroke Action Coalition, I would say, it was just created just close to 2 years, and we are able to make a huge impact. And probably, I would say, the final moment where the individual activities that we're doing, and we all came together. And it was a great moment for the stroke advocacy. And we also had multiple side events, and in the center you have representation from WHO, and in the right-hand side is Ministry of Health, and the Minister of Health from Egypt. I had met him in one of the trips to Cairo, also a great man. And Egypt really pushed this resolution and gained support from other countries as well. And also other side events that we organized during the World Health Assembly. I was able to participate in multiple events and give emphasis on the stroke resolution. And this slide summarizes the entire resolution. Why it matters, I already mentioned about the global burden of stroke, and then the executive board of WHO, and the 3 core structural areas of resolutions are primary intervention across prevention, acute care and rehabilitation, surveillance and data. And what in the right side you can see request to the WHO Director General directly from the headquarters They need to help the countries to come up with technical tools, integrate stroke into existing cardiovascular and neurological global strategies, support the LMICs, work on the universal health coverage, uh, come up with cost-effective intervention, equitable access to medicines, and establishment of regional centers of excellence, and also monitor the progress. So the countries have to come back and report to WHO. And I will take component by component. The first is the population level prevention. We need to look at risk reduction. Key action is focus on hypertension. Yes, there are other risk factors. And how we know that we are progressing, it's a risk factor control coverage. Second is a primary care readiness screening, the early detection. An indicator is hypertension control and medicine availability. An emergency and acute care, the time-dependent response, recognition of symptoms, reperfusion therapies, and time to treatment. So that would be an important indicator. And rehabilitation and long-term support, we have functional recovery, multidisciplinary rehab programs, and access to rehabilitation and outcome would be the indicator. And data registries and surveillance, we have measurement, national registries, registry coverage, and outcome reporting. And lastly, the very important one is the financing, sustainable delivery, the universal health coverage packages. We need to integrate the stroke being covered in the universal health coverage package and minimize the out-of-pocket burden on patients and relatives. So the checklist, for the countries. First question is: do we have a national stroke care pathway? If not, please establish one. Do you have a stroke registry with minimum data set? And we need to establish that before we launch the program. Third, the clinical guidelines, whether it's available or not, and which could cover the prevention and long-term support. And fourth is the universal health coverage benefit. We need to prioritize that, and then do workforce and monitoring system support, sustainable delivery. We need to build on the skills development, capacity building, guidelines, etc. So this is a summary for the countries, and we'll be working on that. And what next? So we had a discussion with the WHO headquarters, the main team. I showed the photograph. So we are going to work with the WHO regional officers, disseminate about this particular resolution, like what we are doing with the Indian Academy of Neurology, develop a toolkit which is available from World Stroke Organization, policy brief on economic impact and cost saving. This should be ready by October this year. Capacity building of primary care program managers, a systematic review on surveillance data, manual for stroke registry. We are from our WHOCC. We are almost in the final phases of coming up with this manual with WHO CRO, which could be adapted by all the other regional offices and the countries. And quick deliverables like WHO headquarters involvement in the World Stroke Congress in 2026, World Stroke Day, and also in some of the we are planning to have a demonstration projects in Africa and Asia. These are the important deliverables that we planned, and we will work towards that. And what about India? I will just quickly talk about the National Stroke Action Plan. This was the executive summary was released by our Honorable Chief Secretary of Health in New Delhi in the National Stroke Summit in 2025 January with Indian academic healthcare professionals in the parliament. And then a group of WHO board members from India, and also the future stroke leaders from India, we worked on this. It took almost 7 to 8 months time. And then this was released by our Honorable Union Health Minister, Mr. J.P. Nadda, and also the State Health Minister for State Health on March 24, 2026. And this is a summary slide about the key targets for by 2030, reduce the absolute number of strokes in India by 10%, increase the IVT rate and EVT rates. I showed the figure, for IVT and EVT rate from the hospital-based stroke registry, treat 90% or more all patients of stroke in India, replicate the hub and spoke model, integrate telestroke services in the universal health coverage, train non-neurologist physicians, and 50% of the medical colleges to have stroke units, 10% of the medical colleges to have EVT facilities, and also deploy mobile stroke units in remote areas. So this is one of the projects that we had worked with ICMR. Two MSUs were deployed in Tejpur and Dibrugarh. Tejpur, there are no neurologists even now, and the program was run by physicians. And in Dibrugarh, there's one neurologist from the Assam Medical College. And we were able to show 90% of patients treated directly from their homes, integration of MSU with 108 ambulance, and we are able to expand its reach to up to 100 kilometers. And you can see that the slashing the treatment time from 24 hours to 2 hours, cutting deaths by 1/3 and reducing the disability eightfold. So this particular model may be costlier, but for remote areas in villages through telemedicine, we will be, if the thrombolysis drug is available free of cost, now we'll be able to implement this program. So I'll quickly conclude with the Punjab Stroke Project. It's a private-public partnership, and we signed a MOU in October 2024 with the Punjab government, and we had deployed the Cure AI software in about 3 spokes. And through that, we are able to see the scans in our mobile, and we take quick decisions. And through this program, even though it started in October 24, the launch happened in May 25, and these are the spokes. And we have expanded the spokes to all the 22 district hospitals. And this is a great model where thrombectomy is done in our center, which is free of cost. We have a CSR funds available, and now with the Chief Minister's new scheme, which is launched in Punjab a few months ago, we are going to integrate the thrombectomy also through this program. So these are few examples of patients who were transferred from district hospitals. So 2 patients here. Now patient came with moderate stroke, and this is the admission and then
पवन
the
जी रुक
follow-up.
जाइए अपना सज्जा
And
हाथ
this is
ऊपर
a
करो
patient,
उमेश जी
same
क्या हाल
patient,
है
NHS 21.
मुट्ठी बंद
You
करो
can
जीप
see the
दिखाओ
hyperintensity,
थल्ले कर लो
latency,
अपना नाम
occlusion, and this is the thrombectomy. You can see the recanalization. This is another patient, NHS 26, and the thrombus was removed. TK3 recanalization. So, in conclusion, this is a great time for stroke, an historic moment, and in the month of May, a standalone stroke resolution was passed by the World Health Assembly. And there's a huge burden of stroke, as I mentioned, and 89% of the strokes occurred in low and middle income countries. We need to really integrate, we need to have an integrated approach, and the resolution has clear deliverables, components, which the countries could work on. And then, as a global organization, and we always tend to work with WHO regional officers, country officers, the ministries of health, and also the professional organization of the countries. We all need to work together to take up this resolution and take it up to our policymakers for implementation of stroke care, and also integrate the prevention programs with the ongoing non-communicable diseases program or hypertension control programs at the primary care level. So with that, I'll conclude. Thank you very much.
Thank you very much, Professor Pandian. It was the whole thing has been summed up so very nicely, so that we have a bird's of view of what has happened behind it. I completely appreciate that so much more has happened to bring that into the table of the World Health Assembly. That's absolutely. There are a couple of questions there, but before we take on to that, this is such a big task. And the spectrum of care from prevention to acute care to post-stroke rehabilitation always remains a challenge in a disease like stroke because it's across various spheres. One is at the prevention where we are not able to get the people, the public in time, and the post-stroke where the patient moves out of the hospital and the clinician like us are not able to gauge perfectly. So when we look at this implementation and accountability, most countries would really be endorsing this global resolution, but definitely would struggle for implementation. And what do you feel that in a country like India, what are the biggest barriers you feel in India? Where would we be lagging behind?
Yeah, yeah, it's an important question. It's a challenge, because of our healthcare system. It's largely private healthcare. Of course, the public healthcare, government healthcare is growing. What we need is, developing acute care. We need to have stroke units, number one. We need to invest on stroke units, which is there in the national NCD program. And there is funding available from the central government to the state government through the NCD program to start stroke units. And there are at least 9 states where this hub and spoke model has been successfully implemented. I would give the example of West Bengal, where the Bangalore Institute of Neurology, along with all the district hospitals, they have implemented this hub and spoke model, and they publish a huge amount of data with use of telestroke. So, in public healthcare system, it is doable, and in the midst of this, starting stroke units in district level hospitals run by physicians, not neurologists, run by physicians. So it is the movement has already started. So first thing is a stroke unit in government hospitals. Of course, private hospitals are easy to establish and run, but the challenge is the poor patients, who go to these hospitals, they need to get the right treatment on time. So availability of thrombolytic agent in the acute care, that is the next thing. So that is also integrated now. Many states have started using from TPA to TNK, so easy to administer, cheaper than TPA. So in that way, there is a cost also for the state government is less. So through this NCD program, there is a provision to start stroke units and run this program. Then for prevention, already we have programs in place. The India Hypertension Control Initiative, which received a UN award, and along with hypertension, they have added diabetes screening and monitoring by ASHA workers, the medical officer, algorithm-based treatment, and so diabetes and hypertension, it's already in place. So we need to just expand that program and more people to be screened, to be put on medication and control the blood pressure. So if you achieve that in the next 5 years, automatically, the primary prevention is going to work. And the most challenging is the rehabilitation, because I showed the data from Ludhiana registry where, people die. That is a hard fact that we need to face because the post-stroke care is so fragmented. Relatives don't have any idea how to take care of them. They will develop bed sore, they will develop pneumonia, and they will die at home, or they'll come back and get admitted and they'll die. So first is the mortality in post-stroke care. That is a big challenge. Second is the rehabilitation. How we can deliver and sustain rehabilitation. So that is where a lot of innovation is needed. So the core thing is caregivers. We need to really empower, whether it's a professional caregiver or the relatives. And some people have capacity to have professional caregivers. That is also fine, but we need to empower them, train them to, particularly if they're a modified ranking scale 4 and 5, they need to, monitor them carefully for complications. So if somebody is in modified ranking 3, Then, the exercises, of course, active and passive exercise should be done. We need to train, empower the caregivers and community health workers. So that is where we need to have models. In India, what is happening is the ashas, they are in charge of the villages. They have maternal and child care. They have infectious diseases program, vaccination. They have NCDs. They have to do a lot. So somewhere we need to segregate whether if the government could budget on NCD ashas, then we'll be able to integrate all these components as not only stroke but also palliative care, chronic kidney disease. We could integrate many of these things. So probably that is the way to move forward in terms of post-stroke care to avoid complications and reduce the death. Of course, they need to take secondary prevention drugs, etc. And the rehabilitation part, that is where I would say technology, digital technology. Empower the caregivers, use digital technology like what you have developed, tele-stroke rehab, tele-neuro rehab, and that is where how we need to move forward. And of course, there are other high-end technologies. If they come to the hospital, we could do that. We could provide those services, robotic, low-cost robotic, and several technologies are there. So these are the ways that we'll be able to implement stroke care, and not only prevention. Prevention we are doing very well in terms of programs, which are centralized, well-funded at primary care level. We have this health and wellness clinic. And I think Ayushman Arogya Mandir, it is called by the central government, and in Punjab it is called in a different name. There's a different name, but they have scaled up in a different way. I think that same Delhi model was implemented here. Um, so we are slowly moving towards that, and the Ministry of Health and Family Welfare, the new guidelines that will be released maybe this year, we have incorporated all these aspects into it. And couple of national level webinars were held. In one, I think Dr. Padma and me, we were involved in training the health manager, the program managers of NCD across the country. Recently, Dr. Ivy Sebastian from the WSO board, she last week only, there was another training program for the program managers. So, people are being educated, people are being sensitized that stroke is important, early recognition is important, and we need to have the stroke centers or stroke units in district hospitals. And private is, of course, no, currently it's largely delivered in private healthcare. And a private-public partnership is also good because there are several states where government to invest a CT scan is going to be very difficult. So that is where the private-public partnership in many states it's happening. District hospitals, you have MRI, you have CT scan, and some states like Tamil Nadu, Kerala, and I think even Andhra and Telangana, maybe the government has invested on the imaging. So it's up to the government, state governments to decide and how it can be done. There are models available for our country.
Yeah, thank you. Thank you very much for that. I completely agree with that the community health workers and the ASHA and Anganwadi, they're actually a little bit overburdened. And I feel that myself when I go for the community health train the trainers program and the community capacity building, they are already with a lot of files and they have a lot of things to be entered. And by the time we are talking to them, I feel that half of them, they are in a not in a mental state to really get to and get connected to us in the stroke pathway, because they are in the maternal child health vaccination pathway and they are really overburdened. It would be worthwhile to have them, a couple of them who are exclusively trained for NCDs, but that probably might not also be possible because all of them meet different set of people. So if these people only would have to meet the population, then that might also become difficult. However, challenges still ensue. We continue our community health and capacity building irrespective. And we are very thankful to the DMHO at Nellore and all the community health workers and the PHC doctors who oblige with us and give us the slot time when I go and give the capacity building for them. We have another question, Dr. Pandyan, here. From a patient's perspective, what is the single most important change this resolution could bring if it is implemented effectively?
Yeah, I think from the patient point of view is access to care. So governments have to provide, whether they have insurance, private insurance, or Ayushman Bharat, or different state governments have their own insurance schemes, irrespective of whether they are able to pay or not able to pay, or insurance is covered, access to care. So that will be a major thing, and they can demand. No, so this is this, and in many hospitals now, patients demand there is an injection that can be given for stroke patients. And so that would be the patient's rights, I would say. Yeah.
Yeah, yeah. So we have so many young neurologists in this forum, and a message to them, Dr. Pandyan, if for young neurologists and the healthcare professional, with this historic resolution that has happened, how can they contribute to ensure that this makes any meaningful change for the patients?
Yeah, so one, as practicing neurologist, if you look at those four pillars which I mentioned about the pragmatic recommendations, and also in the World Health Assembly resolution, prevention. Prevention, that is where, as an individual neurologist working in a hospital, or you have your own practice, screening. Patient may come with headache, epilepsy, but you will have a baseline measurement of blood pressure. So that is where we can play a major role. Counsel them about diet, physical activity, and if they have hypertension, diabetes, put them on treatment. Of course, they would have come with the primary problem of headache or seizure, but if we tag on these things, that itself will make a huge impact. That is number one. Number two, all of us, should have an outreach, some once a month, or based on the person's availability, timing. Work with government or work with NGOs and do rural outreach. That is where we can play a major role, creating awareness about stroke and awareness about risk factors, the importance of controlling blood pressure, importance of taking medications regularly, health education at a rural population. So I would say these are the two important areas that we could work as a young neurologist and in the early career. Of course, in a hospital, you can establish stroke unit, you can provide acute care, thrombolysis. Those are all, by training and attending few workshops, you'll be able to gain the skills. But from a larger perspective, I would say prevention is one area we can contribute a lot.
Thank you very much. Yes, as you rightly said, we had a hypertension drive in the hospital itself, and we did convenience sampling. Actually, whosoever the patient came with, we took all the relatives as well, the bystanders, the caregivers, and we found that the amount of hypertension we picked up at that point of time was so huge that, in fact, we were not able to understand whether we should continue it, because it's just a convenient sampling to convince them that they have hypertension was the next big challenge, because it was just that they just sat down and did. But then at least we could point out to them that you have got your blood pressure raised, as rightly pointed out by you, that is one small thing. Having a manometer and checking the blood pressure would be a huge change, because we know that 80% can be prevented in that manner.
Yeah.
Thank you very much, Professor Pandyan. I
Thank
do not
you.
see any other questions. Thank you so much once again. And hopefully, this resolution is going to have a great impact on the patients, caregivers, and to the healthcare community to see less and less of stroke in the further. Thank you very much. And thanks to all the
Yeah, thank
attendees.
you. Yeah, thank you. Yeah, I think I could see a lot of young people, so it's great to see that. Yeah, thank you. Okay. Yeah.
Thank you very
Bye-bye.
much. Thank you. Bye-bye.
Thank you.